the same month. 2014, February, Ebola hit Liberia. 2020, February, Corona hit Liberia. When you look at the fiscal year ending, so that would be what? 2014, February is what fiscal year? It's 2013, 2014. The revenue numbers show that the projection of revenue, domestic revenue only, was 520 million. So we projected in 2013, 2014, before Ebola, that we would collect $520 million. When Ebola struck and the budget year ended in June, we're still in the fiscal year where the year from June, June, revenue realized was short by around $47 million. So that was the Ebola shortfall in the year that Ebola hit. In the year that Corona hit, that would be 1920, February, we projected a revenue of around 465 million. And where did revenue end up? It ended up somewhere around 27 million short. So we're comparing 47 million short to around 27 million. So 47 million, the way to see it is 2 months' salary. 2 months of government salary was the shortfall in Ebola. A little more than 1 month of government salary was a shortfall in the case of Corona. When you take the revenue numbers, when you take the growth numbers, and you tally all of them up, you see that the impact from Corona is less subdued than the impact from Ebola. The other stunning thing is that I look at the year after Ebola, the full fiscal year. So you're looking at 13-14, then you say, okay, 14-15, the following year, revenue recovered under Ebola, but the bounce was negligible. It was like 17 million. So the recovery under Ebola of revenue, domestic revenue, we're not talking grants, was $17 million. The recovery in the Corona case, that would be what year? 1920, that would be 2021. In the fiscal year 2020-21 that ended, the revenue bounce, and this is the year that we say now grew by 5%. Revenue difference was 101 million. 101 million. So the management of Corona, the evidence shows that the management of Corona dwarfs the management of Ebola. But for good reason, I stated a good reason. We learned some lessons from Ebola that we brought in the management. Well, the first major reason is that God. Let me say that, right? We say thank you to God. Thank you, Swah, for that change. So God get the glory first. Then when we move God from there, now we say, okay, the effective lesson we learn from Ebola, and then the macroeconomic management account for much of the difference. Okay? Academic universe is effective planning, and the question is, as I've said, our policy environment is fine. Our investment size is okay, whether it's money spent on Ebola, in several countries. Look, the Paris Agenda on Aid Effectiveness was supposed to allow developing partners and governments to work together to solve development problems. But I argue that agenda has been displaced by seismic events. Several things have pushed that agenda to a side. What are some of those things? For example, in 2007, we had the Great Recession, the financial crisis that almost brought the world to its knees, right? We're worried about that. The Busan Accord happened sometime 2002, in the early 2000s, and then it was overtaken by the Great Recession. Well, the world was in total chaos. Financial markets were melting, collapsing. After that, what happened? The Great Commodity Collapse. The commodity collapse took the price of iron ore and rubber from the high to low. In Liberia here, we came from $185 per dry metric ton. $185 in 2009 to $65 by 2016. So if the government of Liberia is receiving $65 in 2016 for 1 dry metric ton of iron ore, where it was receiving $185, you can clearly see how the Great Crunch affected Liberia. And that also exacerbated the Ebola situation, because this is the same Ebola period. Commodity collapse, that happened. After the commodity collapse, we go into COVID-19. After COVID-19, we are into Ukraine war. What time does the international community have to talk about the Paris Agenda? Paris Agenda is done. Nobody's paying attention to the Paris Agenda. So government and countries are doing their own thing. Development partners come and bring the money to do what it is. It will take the exertion of countries themselves, countries like Liberia, to bring the Paris Agenda back to the table. So I'm bringing it back to this conference and say, look, we don't have a funding problem. We have a funding organization problem, a coordination problem. And according to the agenda, we should coordinate better. So this is why the government led by the Ministry of Finance has done extraordinary work in working with our partners to move us to the next level. This next level here is actually about pandemic preparedness. So when we say pandemic preparedness, how do we reallocate available resources, even as we are moving to find more resources, how do we reallocate so that institutions like MPhil that's hosting this conference is better situated at the center of pandemic preparedness? We want to bring that to the table. We want to engage our development partners and say, let's talk the beast pandemic preparedness. Let's talk MPhil, let's talk Ministerial Health. The government wants to do X. Can you do Y? But I got you saying that some of the partners are saying the funding is drying up. No, the funding cannot dry up right now. This is the time for funding to be rationed up to solve the problem of pandemic preparedness. As a country, we are prepared to engage the international community using existing tools. For example, as I mentioned, the Resilience Sustainability Trust of the IMF. There are other similar programs that are on the climate change in the climate change space. Liberia wants to apply under this IMF program. We want to apply using that for climate change purposes as well as for pandemic preparedness. And the main actors are going to be MPhil. So MPhil, you got skin in the game. But the government is also going to do more. You know, as much as we're talking, the paradigm is why Liberians could walk 1 hour to a health facility. So when you look at the fact that out-of-pocket costs were low relative to the other countries, that people had access to a health facility even almost 10 years ago, we could not reach the conclusion that health was a binding constraint, though it was a major challenge that we continue to solve. Why am I saying this? After 10 years ago, look where we are now with physical infrastructure in terms of hospitals. The Melody 14 Hospital was built 3 years ago. I think 3 years ago it was delivered. We just opened a new hospital in Riverside. It's an 80-bedroom hospital. And we're building 8 more hospitals in the southeastern region under the German government funding. So Riverside plus 8 more in the entire southeastern region. We have the Bapulu 100-bed facility. We're talking John F. Kennedy remake. You know, it could be an investment of $25–30 million. We are talking the hospital in Buchanan, and we're also talking the hospital in Saniquili, the relocation of the Saniquili hospital. Saniquili is sitting where the train passes and disturbs the patients and the medical workers. So the government is working with ArcelorMittal to move it from that location to a new location and make it grander than it actually was. When you look at all of these investments in human infrastructure, what do you think the proportion of people who have to walk 1 hour to a healthcare facility? They will move from 72%. I mean, I haven't looked at the current data, but it has to move from 72%. It has to go to upward of 85%. Clearly. So it means we are meeting the access to healthcare need. The big question then is maybe the quality side, training. This is where again funding for MPhil. Let me thank all the development partners, that CDC, that USAID. They have funded you to the extent of buildings, right? Your lab, your technology. So we can give it out to them for that. The question is, what is that next generation that puts you in a top tier of the management of pandemic and epidemics in the country? So the government has to do more, and we're saying beginning in this current budget, we're doing more. So beyond the hospitals that have been built and are being built, we're also looking at at what the Minister of Health is calling the comprehensive health plan, or comprehensive health sector, she calls it. So she's saying when the hospital in Magibi got burned, the new facility now, the quick fix, they transform it into something called comprehensive. It's self-contained, it has everything. Her argument is that every county has to have a comprehensive health care. We have the budget for that. Our argument is also that midwives all over the country need their own comprehensive health center all over the country. The plan of the government for the next 10 years is to continue every county to build centers for midwives, to also look at traditional midwives who are not on the payroll of the government. When the president went to rural Montserrado, he was met with that challenge. The first they said, oh, midwives are not on the payroll. And I turned to the minister, no, she was not there. I called her. Midwives not on the payroll? No, we paying midwives. No, it's not midwife. It's traditional birth attendants. So those ones are not on the public payroll, but they are delivering. So somebody is working in a village, okay, but they're not on the public payroll. Maybe they get small stipend here and there. So they are advocating to get on the payroll. Well, to get on the payroll, if you put all traditional birth attendants on the payroll, somebody said, well, before you increase the salary of the midwife, because we're trying to say, why don't you also put the other ones who don't have public payroll, don't increase. So that's a challenge we face. Do you increase or do you add more to the public wage? So it's a constant challenge. So you can clearly see that the government is committed to making bigger and bigger investment in the health sector to support the health and economy nexus. All these investments are necessary. They are elements of pandemic preparedness. Okay, we have to be prepared for the next epidemic. If you don't have skilled traditional birth attendants on the payroll, you're not paying them adequately. Maybe they'll be doing inefficient service. They will be doing less standard service. And that could pose problems for health and all of that. So it's a whole package. The government is committed to doing its share. My argument is that our argument as a government is that we want development partners to come along with us in this logical matrix that looks at holistically all of the problems in the sector, all right? Whether it's related to epidemic, it's related to maternal mortality, infant mortality, all of the different challenges that we have to solve, we got to plan and do it together. If we do it in the way we've been doing it, we get the same result. We get the challenge that we spend a lot of money, but we still say the challenge is big and big. So the policy has been right to some extent. The financing has been right. It's the combination of the financing and the type of investment we are financing that has been the problem. In this post-pandemic age, let us work together under the Paris Agenda for Aid Effectiveness as government, the private sector, and development partners to reorient public spending in healthcare to move the Liberian people to another level. Thank you very much.